Hello, thank you for joining us today. We're going to go ahead and get started. This is challenging case competition, peripheral. We have some exciting cases to discuss and show. We're going to start with Sarah Misbah, Transulnar access for bilateral SFA PCI and angioplasty.
Yes, Dr. Pita, indeed. Good morning, everyone. My name is Sarah Misbah. I'm a PGY2 internal medicine resident at Texas Health Resources HEB Denton. And today I'll be presenting my second transulnar case, and this is a transulnar route for simultaneous bilateral SFA angioplasty. So I have no disclosures. Our case, basically a little rundown. We have a 70-year-old female. She's very well known to the cath lab. She's had multiple cardiovascular procedures done by our cardiac team. Her main complaint was bilateral lower extremity claudication, rest pain, paresthesias, temperature and color changes, so we know that her limb is pretty bad. A little bit of pertinent cardiovascular history just to give you a scope of how bad this patient is cardiovascular-wise. History of premature CAD, she has familiar hyperlipidemia, cabbage with occluded vein grafts, multiple PCIs and stent placements, and extensive peripheral vascular disease with prior stents and in-stent stenosis and a hypercoagulable history as well. We have a arterial duplex. Tried finding a video, but we have static images for you. We have mid-SFA critical stenosis. There's monophasic flow. We know we have to intervene at this point. We did a CTA or a runoff. It shows a stent in the right SFA. There's moderate to severe multifocal narrowing throughout it. We have severe narrowing with near complete occlusion over a 2.2 centimeter long segment of the proximal left SFA, and also the right peroneal is also occluded at the proximal calf, and right tibial peroneal, posterior tibial, and the left posterior tibial and peroneals as well. Just a little static image of the in-stent stenosis that we have. Our challenge here is that we knew this patient. We knew we were not going through our groin access, and we wanted to proceed with transradial. However, when we scanned the area, it was found to be occluded. It was inaccessible, but it did have low flow. So now what? We decided to proceed with the ulnar access. Again, we made sure there was good collateral circulation. We've had experience with transulnar procedures in the past, and so our operator was very confident going through this route. We prepped our right ulnar. We again placed a 6 French sheath. We put in a 6 French slender guide sheath into our right ulnar access. Just a little, I'll play this later, but just a little pre-intervention before I proceed. Really bad disease, as you can see. We have like very faint runoff in the tibial on the left. For us, then again, after this, we did the guide wire insertion, guide sheath. We inserted our catheter. We did a sheath exchange and put in the R2P 6 French sheath guide. We exchanged the sheath and put in a run-through wire and threaded it through the aorta, the iliacs, and then finally into the left SFA. It was very hard to wire. However, we were eventually able to make it through without having to escalate wires or change it at all. But it did require some protracted wiring, eventually able to deliver shock waves. We did have some complications. One of our balloon ruptured after 2 inflations. We took it out, put another one in, 5 inflations, pretty good. We did an angio after that. It showed pretty good flow. And then we did a Misago stent placement after that. Just a little rundown again of what happened on the left. After this, we actually went in back to the right side. We did balloon shockwave. I think we had like 10 pulses, good flow. We didn't have any stent placement, and sheath removal, and then a TR band hemostasis after that. During the intervention, you can see there's like pretty bad stenosis on that side on the left. Unfortunately, we only have images for the left and not the right. There were some issues with the cath lab. We weren't able to retrieve all the images. And then this is our balloon inflation. And then finally, we have post-intervention, just one static image. Again, some issues with getting images and videos out of the cath lab. Pretty good flow. It was pretty successful. Main learning for us is that I know there was talk about going transulnar versus brachial before, but we've had pretty good experiences and outcomes at our center. There's easier access. It's a larger vessel bore. It's less vasospasm risk with it because less alpha receptors on our ulnar artery. It's a pretty easy learning curve. I think there was one study that showed you need to do at least 50 if you've done a lot of transradials, and it's pretty much the same, and you're able to do it pretty easily. And just be always cognizant that you might need alternate access mid-procedure and improvise accordingly. Thank you.
So I mean, it's great results. One cautionary tale here is when you have in-stent restenosis, you often have thrombosis there. And, you know, you got to be ready to address that and deal with distal embolization. If there's a long stent, very restenose, many times if I cross, I will put a filter down distally. Often we use laser and other devices. And in some of those equipments and ability to deliver things gets hampered by, you know, going transradial or transulnar. It looked like it was pretty straightforward to just go up and over from the left groin. Yeah, you would have had to probably bring the patient back for their left SFA, but that's not the end of the world either. So, you know, we can get away with things, but sometimes if you have a complication, it's really hard to manage from the arm.
You know, I'm glad, thank you for sharing this case, and I don't think it's fair to ask you, but I want to ask the audience. I know we have a great vascular surgeons colleagues here in the audience too. So I'll tell you, we are a very high volume center. We do a lot of peripherals. And when the radial is occluded, our surgeons, due to some reasons, they are very good surgeons. We love them and they help us a lot. But they won't bail us out if we have ulnar complication when the radial is occluded, because medical legally there's a lot of issues with doing that, especially if you have ability to go femoral or, you know, anywhere else. And I don't know what you guys experience in your center, but you know, we don't do a lot of ulnar. Can we do it? Absolutely, it's easier than radial. You know, you can do it. It's not about whether you can do it. It's whether you should do it when the radial is occluded, especially if it's the dominant arm of the patient, or even if it's not the dominant arm. Nobody wants to lose an arm. I mean, your thoughts on this?
Yeah, we do only radial, only ulnar when radial access, of course, is not available. In this case, I'll be very cautious, like as you commented, ready for, I think it's okay to ask the surgeon that we're doing these procedures, and if any complications, then we might anticipate, because one of my colleagues also do the occluded radial artery. He always do PCI with occluded radial arteries. So I think that's doable. Depends on how far is the occlusion and how the occlusion is. It can cross the radial artery into the PCI at least.
I mean, you definitely can.
But yeah. One question that you said that it's in-stent restenosis, right? Did you do IVUS? How do you decide that what size of the shock wave?
So basically we did the IVUS and there was balloon. We did the IVL shock wave, and this was a very well-known patient. She's had been following up in our cardiac clinic multiple times, so we've been following her bi-weekly, so we know everything that's been going on. A little background on her: she's had PEs in the past, and she's had filter replaced. She's had thrombosis. Despite that, we were aware of the in-stent stenosis. Femorals were not accessible because she had been evaluated, I think, 2 weeks before, and they were, because we knew she had to get an intervention done.
I'm sorry to interrupt. I'm asking during the procedure, not the ultrasound. I'm asking the intravascular ultrasound before the shock wave.
I do not think there was an IVUS done during this procedure.
Yeah, before the shock wave, I don't know. I know that there was a stent before. That might be the reason that in-stent restenosis happened, because it's not probably appropriate size. And if you do the same thing, it's not going to help much. Also, you don't know what this in-stent restenosis, what is the underlying etiology is. So I don't know if shock wave will really help or not.
Just for the sake of discussion, drug-coated balloons for in-stent restenosis? Still using them or no?
Yeah, I do.
Yeah, I think that's. I think that's one place where I like to use DCBs as well. Any questions from the audience? Do you mind commenting as a vascular surgeon, like on ulnar access when you have radial occlusion?
So it's not, I would say it's not very common. And I think the challenge is the risk of limb ischemia, right? So after removing the sheath, there's going to be a compressive device. I'll speak louder.
Sorry.
That's okay.
Can we put the microphone on, the handheld microphone over there? I think it's working now.
He's got it. He's smarter. He's good, more savvy, younger guy. So I think the challenge and the concern is limb ischemia, right? So especially with an occluded radial, and there's the post-procedural compressive period and the risk of thrombosis. So I think it's just almost like a cautionary tale, meaning, you know, you got to be on guard and have a low threshold to make sure, you know, if the hands are starting to have symptoms immediately after the compression device is removed, like you can't really sit on that for long. We tend to not see those very much in our group, but you know, that's just a practice pattern. But I think the risk is real, so just something to think about.
Thank you.
One more question. One more question, yeah.
In terms of definitive management, if the primary mechanism is stent failure, then won't a Ranger DCB, which you can deliver through a U2P platform or R2P platform, be better than putting a Misbah stent, which is non-drug-coated?
So the Misbah was not placed in the site that had the in-stent stenosis. We did bilateral. The left was the one where we had the in-stent stenosis, and we did the balloon and multiple shock waves, and then we expanded that with the stent, and then the right one, it was the one that was without the in-stent stenosis.
Thank you very
All right,
much.
thank you. So our next presenter is Dr. Tigen, total percutaneous restoration of CNS flow in a patient with Takayasu's arteritis.
Thank you very much for giving me a chance to present my work. And this is a case from our institution from Turkey, and percutaneous restoration of central nervous system flow in a patient with Takayasu arteritis. There's nothing to declare. The patient is a young lady and presented to our clinic with confusion, amnesia, somnolence, and syncope. Actually, she was under follow-up for Takayasu for 16 years, and physical examination revealed pulseless upper extremities and the cardiac arteries. CT angiography also revealed all the vessels supplying the central nervous system and upper extremities were occluded. And after having, this is the angiography first, and this is, you see that the right upper extremity is also occluded. There is no blood flow. And this is for the left. This vessel is supplying the central nervous system, and the subclavian artery to the left is also occluded. So vertebral system and carotid system are all occluded. And the patient, this is the central nervous system with the dye perfusing from the left carotid artery, just that one. Rheumatology, she was under follow-up for rheumatology 16 years, cardiovascular surgery, neurology, and our team has a discussion and consultation on that patient, and we decided about percutaneous stage revascularization, restoration of central nervous system blood flow, because if we wait a lot and if we lose that carotid artery, and there will be no sufficient blood supply to the central nervous system. But we have potential risks, we know that, embolization and acute periprocedural stroke, and which vessel to start first, because one of them is totally occluded, one of them is subtotally occluded. And intervention for an occluded carotid artery should be a complication and not good for that. Balloon dilatation or stent implantation, there's no data about that. Single or both carotid arteries for intervention, just opening one and waiting for the next one. And medical therapy after that. What should we do for that patient in terms of anticoagulating or antiaggregating therapy? So these are all were concerns, and we discussed about that, and we decided about stage procedure because we do not like to lose one of these vessels because they are semi-occluded now, and it's time for intervention. Both interventions performed in appropriate support catheters and dedicated CTO wires and microcatheters, dual lumen catheters, and balloons with experienced CTO operators. And after recanalization of that vessel, then we changed into glide wires and delivered peripheral balloons and stents to that segment. No filter devices were used because we know that this is not an atherosclerotic stenosis, and this is something quite different. And dual antiplatelet therapy for 6 months after following the intervention was decided, and 6 months CT angiography was planned after intervention. This is the procedure for right common artery. After engaging that, we realized that this is not something like an atherosclerotic. There are channels inside, and there's a tiny filling at the upper side of that. So we decided to use a microcatheter and reach to that segment and search for channels with a polymer jacketed wire, and this is Gladius. So I managed to find the correct way to reach to distally to that vessel, to that occlusion. And after that, there's a tip injection here, and we see that this artery is external, internal carotids, and we have a bifurcation there. So we delivered a dual lumen catheter there. Again, this is a Gladius, you see that. And after engaging that part, we managed to get the internal carotid artery. And after that, we delivered the microcatheter up and made a tip injection. See that? The tip injection that we are in the true lumen, and after that, we have the balloon dilatations to that segment. And this is it. And while we are doing that, we send the bubble. You see that in the upper side? We were cautious about that, not sending, but there was a bubble, but nothing happened. So we decided to implant a stent because we know that after balloon dilatation, it is something like a rubber. You are opening it and it is recoiling again. So this is the stent implantation, and the next stent to the proximal part, ostial part, and after that, you see that total restoration of the central nervous system.
What stent and what size?
These are, I do not know, I do not have the names actually. These are the sizes, and 6 and something like that, self-expanding stents. Some of stents are available in our country, not available in the United States, and it's different. Yeah, it's different. This is self-expanding, and 6 or, yes, please. So how often do you use IVs for that purpose? I can say that I can never use it, because this is not something atherosclerotic. This is something fibrotic, and this is occlusion. You know, 2 weeks later, we brought back the patient to the cath lab for the left side. And this is a bit, you know, easier, but you see that this channel is not a real channel. There are some fillings. It's like something like a woven. So again, a polymer jacketed wire, a microcatheter down, and after that, I managed to go up with gentle manipulation of that, you know, you see that, the wire, and finding the way, and opening the vessel with balloon dilatation, and after that, stent implantation to that segment again, and post-dilatations, and this is the final result for the right side. You see that side in the bulbous, and we managed to open that part, but it resisted to 6-0 balloon, and we left it like that. Because, you know, I do not know what is that behind that. Maybe IVUS might be helpful in that vessel. So here is the final, doing good, and this part is also supplied. And the patient was taken to the intensive care unit, and the issue is that while you start perfusion, the patient is suffering from hyperperfusion syndrome. She had a severe headache and edema and some kind of neurological disorders, and you have to be so cautious in terms of having this normotensive at least, and the risk of bleeding is so high in the period, so you have to be so cautious. And we had the CT scans for a while, and after that the patient is doing well. And it's safe actually and effective in especially great arteries. If you have a skilled CT operator, it is something like that, not to just create a knuckle and go up, because it is central nervous system. And procedural success rate is high with dedicated wires and experienced operators. And you do not need any kind of protection devices because it is something different from atherosclerosis. It is something like a fibrotic tissue. And restoration of central nervous system increase pressure and lead to hyperperfusion syndrome, and close communication with the neurologist staff is mandatory in such kind of situations. And this was my final slide. Thank you for your attention.
I have to admit, this is an amazing case. Congratulations.
Yeah,
I
this
think
is so
patient
rare,
is lucky
actually.
to have you guys.
Yeah, this is so rare. So we wanted to present this. You know, there's a guy from India, and he is dealing with such kind of patients. He is intervening all the arteries that are occluded in Takayasu disease. And upper extremity arteries are very, very risky, because the anatomy of the arteries is challenging. I mean, they're using just plain balloons, drug-coated balloons. We also used a drug-coated balloon in a patient with rest stenosis after stent implantation. But stent implantation, especially self-expanding stents, are quite safe. You do not need to use a filter for protection of the central nervous system. And after that, rheumatology, immunosuppressive therapy is very important because this is something like immune reaction. So you are opening the vessel, but it's occluded. And to be final, I want to say that intervention per patient is 2.6 in his series. I mean,
It's the guy from
yeah,
Valor in India.
I do not. Yeah, it's for India. India.
published
Yeah,
in JACC,
yeah,
the
yeah.
largest series
2.6, and it means that at least 3 times intervention per patient, and rest stenosis is very high. But in such cases, you have to restore the central nervous system for all. You do not have anything. Surgeons do not touch this because they know that it's very complicated and very risky. So this was a nice case, and I wanted to present this in that nice meeting.
Yeah, thank you for the presentation. Any questions from the audience? Let's start with here, then we'll go there.
Thank you. Excellent case from Turkey. So my question is regarding in-stent stenosis. In this particular patient, that was bilaterally, and I think you did an excellent work there. But how do you estimate the risk of in-stent stenosis, especially with the fact that this was not intravascular image guided? And do you think you're going to bring the patient back for another angiogram or use non-invasive CT angios? And if you do, how often do you want to do that?
Yeah, nice question. Actually, our neurology, rheumatology team is a well-known team in the Marmara University in Europe, actually. They are following lots of patients with Takayasu diseases. The main thing is to intervene the patient while he is stable. I mean, immunologically, and your acute phase reactants should be low in normal. So first of all, we are having the patients to the clinic and suppressing the patient with the medical management of rheumatology, and after that, intervening. This is directly related to rest stenosis. I mean, if the patient's condition is stable in terms of immunological manner, so these patients present less rest stenosis. But the data is controversial, using plain balloons, using drug-coated balloons, using stents. All them are doing the same work, but you have to follow the patient at least 6 months with CT angiography, as you mentioned.
Thank you. I know we have another question, but we're 2 minutes behind. If you don't mind, if you want to talk in private. Thank you. All right, we'll go next. Very good case. Thank you very much. Elizabeth Fesko, microchannels and peripheral CTOs, illusion or reality?
Good morning, everyone. I am Elizabeth Fesko, and I am presenting on behalf of Dr. Shadi Hlavaty, who was the physician that performed the case. We are affiliated with Powers Health in Munster, Indiana, and the Indiana University School of Medicine. I have no disclosures. So there was an 82-year-old female who presented with a non-healing right lower extremity ulcer. The limb was blackened. Her main complaint was pain walking. She couldn't walk more than 500 feet. Past medical history was significant for diabetes mellitus type 2, hypertension, hyperlipidemia, aortic stenosis, status post-TAVR, and stroke. Patient presented for a second opinion after major amputation was recommended at 2 outside institutions. A duplex arterial ultrasound revealed a complete occlusion in the anterior tibial artery and abnormal monophasic flow of the perineal and posterior tibial arteries. In a CT runoff angiogram revealed a patent aorta, iliacs, CFA, SFA with an occluded AT and TP trunk. The angiogram showed patent superficial femoral artery and popliteal artery. For this case, the superficial femoral access was favored due to the patient's weight. They could not get a good common femoral artery access. And there was a complete occlusion of the AT and the TP trunk with significant collateralization, as seen in the image on the right. The initial wiring attempts were using multiple 014 and 018 wires, but they both failed to cross the blockage. The antegrade crossing is the preferred initial method of crossing chronic total occlusions. As the retrograde access, this patient had a single vessel runoff, so it posed an additional risk to trying to get it retrograde. And the 014 and the 018 are currently the mainstay wires used for crossing of tibial chronic total occlusions. However, we presented a case where we used an 009 wire to try to deviate from this normality. Histological studies from the coronary literature have shown that microchannels, which are usually around 200 microns, are frequently evident in CTOs. Similar to coronary CTOs, we hypothesized that these same microchannels could be present in peripheral CTOs, and they are not taken advantage of. So we tapped into the coronary world and used inspiration to use an 009 wire, but in the leg. This was successful, and it was able to cross both the PT and perineal arteries.
What wire did you filter, or what was the 009 wire?
I believe it was a glide wire. Don't quote me on that. The IVUS was completing, confirming interluminal passage of both wires. The final angiogram revealed brisk flow in the TP trunk, PT, and perineal arteries. IVUS confirmed excellent lumen gain with no significant dissections. The takeaway from this case was there may be an important role for tapered 009 guide wires in finding microchannels in peripheral CTOs, which may obviate the need for retrograde access or subintimal crossing when microchannels could be present. And we propose ultimately tapping into that coronary world and bringing it to the peripheral, because sometimes a more delicate approach may be more useful. Thank you.
Yeah, you definitely try what works, right? I mean, this is the peripheral world is a little bit more forgiving than the coronary world, and then whatever works, works. Just a question to the panels. Who would have done the, down stick, especially in an obese patient, that low stick versus go just pedal, even with single access? I think the nice thing about doing it from above, you were able to fix the bifurcation stuff. That would be more difficult from below with the single pedal access. Thoughts on single vessel runoff and pedal access?
So I will talk loudly. So I think in this particular case, right, so certainly getting a pedal access would be worth it. I mean, the vessel is occluded, there is nothing to lose, and also gives you a little bit of pushability. Hopefully helps you restore at least that at least the trunk, or get access into the main lumen upstream. That way you can work from upstream down for the other vessels. So I think it's worth a shot. And as you said, it's an obese patient, so there is a hesitation, from the cath lab staff. So, you have to prep the pedal, you have to prep the groin. So I think if you prep it, if you have the game plan well in advance, I think that will overcome their hesitation. I mean, they are mentally prepared to stick the pedal access. So
I didn't see an angio of the foot in your talk. Did you have one?
Yeah, that's the other thing.
So one of the key things for the trainees is when you're presenting a CLI case, you have to have the runoff to the foot. We have to see what's happening at the ankle and the foot. And then the other statement in the presentation about pedal access being higher risk or associated with risk, I'm not sure that's true. So increased risk of complications. You know, nowadays you can use a 4-5 or, you know, a 4 French radial slender sheath, and if it's already occluded, the patient has critical, you know, ischemia, tissue loss, then I'm not sure it's actually increased with risk of complications.
Any questions? Yes, sir. Go ahead.
Oh, it didn't slide up.
Engaging some parts. So, in my opinion, polymer jacketed wires valuable in that part, but if you use that, you can use Pilot 200, for example, or a Gladius, or an Enrich. This is a wire from China, polymer jacketed and 6 grams of tip load. Then you can be more comfortable in terms of while you are operating the patients or you are engaging to the true lumen. Because I know that when you push that wire, this fielder, then it will touch to a calcified segment and it will create a knuckle. And after that, you will follow that with a knuckle. So it doesn't differ. So very long distance, having a microchannel is a very big challenge in these cases. So I would prefer a higher tip load polymer jacketed wire in such kind of a case instead of field rigs or something like
Just
that.
to try and stay intraluminal, because especially at the bifurcation, you know, because if you go subintimal, you know, SFA would be okay, but here you would lose the ability to fix the bifurcation. Again, you know, the nice thing is, you know, multiple options, whatever works is great, but that's a great case.
For bifurcations like this, what are people doing with their Esprit deployments? Are you doing bifurcation Esprit cases?
I personally have not done bifurcations. I've used it for obviously tibial vessels, but not in bifurcations.
Not in bifurcation.
And this is the self-expanding, for people who don't know, self-expanding, the resorbable stent below the knee approved. Self-absorbing.
Yeah. Absorbing, balloon expandable, yeah.
Thank you very much.
Thank you.
Thank you, guys.
So our next presentation is from Dr. Hopper, novel hybrid surgical solution for thoracoabdominal aortic aneurysms.
There you go. All right. Thank you, everybody, for having me here. My name is Will Hopper. I'm a vascular surgery fellow in Dallas at Baylor Scott & White. No financial disclosures, obviously. So my case is a 58-year-old male who presented as a transfer to our institution with an acute type B, 3-9 aortic dissection, back pain, chest pain, as well as an infrarenal aortic aneurysm up to 5.6 centimeters. Patient's history, just hypertension. He was an active smoker. Surgical history significant. He had a midline emergency laparotomy, trauma laparotomy for a gunshot wound in the past. Over the course of us managing this patient, he did undergo genetic testing, which was positive for connective tissue disease. EF largely unremarkable, 45 to 50%, and relatively active. This scan should play. Not sure if there's a trick to make it do so. There she goes. So this is his index and arrival scan showing his dissection. No clinical or radiographic evidence of malperfusion here. And then there's your aneurysm infrarenal, as I said, dilated up to 5.6 centimeters. So we managed this gentleman medically, and we're able to discharge him from his index admission. He returned to the clinic with follow-up, and for a number of reasons. One, persistent, mild chest and back pain associated with elevations in his blood pressure. Being the main reason, we elected to repair his aortic pathology in a staged fashion. So several months later, we brought him back. We performed a TVAR with the Terumo device, and based off his anatomy, we elected to perform laser fenestration of his left subclavian artery. Post-operatively here, and the device coverage was only 15 centimeters. Post-op, he did have some right lower extremity weakness, negative stroke workup, and this resolved with physical therapy. This is his post-op scan from his initial TVAR. You can say a decent result, but he still has dissection in the visceral segment down to zone 9, and then the aneurysm. So the question is what to do for this patient, namely for the aneurysm. One could argue in a challenging anatomical case such as this, 5.6 centimeters, maybe it's better to watch it. However, given his positive genetic testing for connective tissue disease, I think that pushed us towards wanting to intervene. So then the next question is open versus endovascular. Again, historically, folks have made an argument for open intervention in folks with connective tissue disease. However, that is obviously not a benign operation, as you see here. So pooled mortality in all types of thoracos, 11.3%. And folks like him with an extent 3, it's going to be 8%. And obviously, type 4 is about 7, higher mortality from the higher extents. Rate of spinal cord ischemia, permanent dialysis, kidney injuries, bowel ischemia, all non-significant risks. Alternatively, endovascular options, and our institutions, we perform plenty of PMEGs. We do not have an IDE device at our institution. And patient declined outside evaluation by an outside surgeon. So in evaluation, one consideration, and the option that we ultimately ended up going with after obtaining a compassionate use agreement from the FDA. This is a novel device, the Terumo Thoracoflow. If anybody's familiar with the Terumo Thoraflex device, this is similar based off the principles of the frozen elephant trunk. So you can see the device here in the top screen before it's deployed. Essentially, it is a hybrid. It's a stent graft connected, attached to a standard Crawford thoracoabdominal stent. What are the benefits of this versus your standard open thoracoabdominal repair? Well, there's potential, so there's not a lot of data. This case was actually the first one done in the United States, previously one done in our 51st state, Canada. The benefits of this: reduced respiratory complications from potentially avoiding a thoracotomy. Likewise, no need for proximal aortic clamping and associated extracorporeal circulation, which in turn lends itself to reduced coagulopathy and volume shifts, and also creates an avenue where patients with reduced ejection fraction become eligible for this, and then finally reduced visceral ischemic time. So how do we do the procedure? Modified right lateral decubitus position. As I mentioned, you'd like to avoid a thoracotomy as one of the benefits. However, given his hostile abdomen from a previous gunshot wound, we elected to proceed with thoracotomy. You can see in this next picture, we've got the aneurysm fully dissected out from the screen top to bottom, celiac, SMA, renal. We don't quite have the right renal artery looped out in this picture, and then IMA at the bottom. And then this is after the graft is implanted. So the way you do it, step by step, is fully dissect out the artery, the aneurysm. You access the supraceliac aorta, or you can go right at the ostomy of the celiac artery with a micropuncture needle, advance a wire, and then introduce the stent graft. Deploy it after removing your wire under TEE guidance for confirmation of location. And then before you deploy it, actually I should say, you sew one of those limbs. If I can I go back? There you go. So one of these limbs will be sewn into the an iliac artery. You can take your pick, right or left, so that when you do deploy, you then have, when you deploy the stent, then you have inline visceral perfusion into both legs throughout the entirety of the case. From there, you can clamp and sew your celiac, your SMA, a single renal artery, place a perfusion catheter from the right renal limb into the renal artery while you open your aorta, perform your proximal anastomosis, again without ever having to cross clamp proximally, only at the aortic bifurcation. In this case, we lost neurosignals in the lower extremities after performing the renal anastomosis, so we reimplanted both the IMA and a lumbar patch. And then here's a post-op scan, 2 or 3 days post-op, and this should play as well. So previous repair, there's a slight infolding, but not limiting, and patient's doing well. And that small fluid and air collection, again, as I said, is immediate post-op, so not to be concerned. Patient is followed up in clinic and is doing well. He did have, as I mentioned, some spinal cord ischemia, but his paraplegia is rapidly improving at this point, and he's working with physical therapy and beginning to walk again. So takeaways from this, this is a novel, viable option for future management of thoracoabdominal aortic aneurysms. Being able to perform this surgery via midline laparotomy approach for numerous reasons creates a strong advantage. One potential modification to our strategy coming up from the contralateral iliac limb from where you've sewn to, you could bring up a wire and aortic occlusion balloon while deploying the stent. That is one of the periods during the case where you're going to have a high volume blood loss. And so that would reduce your EVL as well during the case. And then this is the surgical performing team. And again, as I said, first done in the United States.
Great case. And excuse my ignorance for this question, but I heard you say you hook up one of the renal arteries and the other one?
Yeah, so the kind of stepwise, after you've iliac anastomosis, and then once you deploy the stent, you now have inline flow through your visceral segment down your legs, right? Then you do your celiac, SMA, and the left renal artery anastomosis is usually easier from that retroperitoneal approach. You're going to do that one first. And then you place a perfusion catheter from what will be your right iliac limb of the graft into the renal artery, and at that point you do that to temporarily perfuse the renal artery while you perform your aortotomy, overshow your lumbars, and perform your proximal anastomosis. So again, there's really minimal opportunity for visceral, renal, or lumbar ischemia.
How many hours?
This case, with it being our first one, he was in the room and out of the room in 8 hours.
8 hours. Any questions? Yes, sir.
Mm-hmm.
And after that, you are anastomosis in the other part, distal to the vessels. How do you stabilize the proximal part? See that?
Yes. So Dr. Roberts, actually next door, presented a very elegant video of the Thoraflex, which, if we had a video here, it would show the graft has a little cuff. And you probably can't completely see it well in this image, but essentially you sew you have your native aorta clamped at the bifurcation. All the perfusion is going through the graft, through the stent into the graft and into your visceral vessels. And then you sew that cuff to your proximal aorta after you've made your aortotomy, and whether you're going to perform a full transection versus an aneurysmorphy technique. But there's a cuff built in that you sew to. At that point, we placed a Ramel, and that's what you want to do. So, the occlusion balloon can also be handy during the proximal anastomosis, because in this patient with a dissection, or if you've got a dense intercostal burden up top, you can have bleeding at that point, particularly from the false channel. You've got your stent in the true lumen. If you still have a perfused false lumen, you can have some bleeding. So a Ramel to provide some compression, general compression around the stent, or an occlusion balloon at that point as well.
Well, thank you very much. Very intriguing case.
Thank you.
All right, we'll continue to move. Endovascular caval reconstruction for congenital inferior vena cava atresia. Joel, is it Hlavaty?
Hlavaty.
Okay, I was wondering if the H or the L is silent.
Yeah, you're right. Yeah, thanks for having me. I'm excited to present this case that I did with Dr. Harth. Here are our disclosures. I have many fewer than Dr. Harth. This is a 28-year-old woman, notably with a BMI of 44, who presented to us with bilateral leg and back pain. About a week prior to this, she'd been diagnosed with PCOS and started on oral contraceptive pills. And this is just a still. I have a cross-sectional imaging on the next slide, but she was diagnosed with bilateral common femoral and femoral vein DVTs by duplex, and a follow-up CT that was obtained did reveal to us that she had congenital atresia of her IVC. So basically from the retrohepatic IVC and then all the way down to her iliofemoral bifurcation, there was an absence of, or an atretic segment. So this presented to us an interesting clinical challenge. So initially, her DVT was managed with catheter-directed thrombolytics to sort of get her back to her baseline. She was discharged on anticoagulation, but also started on Ozempic and was successful at weight loss, but had very persistent edema, venous claudication. She was connected with chronic pain management team, was getting ketamine infusions, and basically came to us successful with her weight loss, but asking for help with this problem. This is repeat venography in the prone position, again just demonstrating these paralumbar collaterals that had developed that she had basically been living on until her DVT unmasked her congenital atresia. And again, we had our cross-sectional imaging that we had showed you before. And so our challenge here was an anatomic reconstruction in the setting of this long-length atretic segment of the IVC, and now having even worsening pain and symptoms due to post-thrombotic syndrome. And so how to address this, just wanted to organize this in some way in my head of how we obtained access and were able to cross the imaging we used and our revascularization. So for access, we were fortunate to have a two-team approach. We obtained access at the right IJ, placed an 8 French catheter, later or sheath, and later upsized it to 16 French, and had 9 French sheaths at the bilateral mid-femoral veins, so she was in supine position. And then we worked from both sides to cross this atretic lesion. I think one of the important things to note is that we frequently used cross-table venography to make sure that we weren't heading into these paraspinal collaterals. Once we were able to cross, we had through-wire access out the right internal jugular from our right femoral vein and our left. We were able to exchange these for more supportive wires. And here's our initial IVUS imaging. There's one still on the right here and one that I think plays as a video that just shows how we used small caliber balloons, 5 and 8 millimeters, to try and crack our way through once we had our through and through wire access. And I think one of the most important things is, using this IVUS to verify our landmarks. We wanted to make sure that we didn't impinge upon her hepatic vein drainage. And so we, once we had you know, confirmed our landmarks and our sources of inflow and outflow. We did do sequential balloon venoplasty, first with 8 millimeter non-compliant balloons and multiple 30-second long inflations all the way up to 14 millimeter balloons. In the Caval segment, we did do these alongside each other in a kissing fashion. And these are all just still images showing that. Again, liberal use of IVUS to verify that we weren't going to infringe upon our hepatic veins. And then the largest peripheral stent we have is up to a 20, and we wanted to be sure that we pre-dilated, oversized our stent, and then post-dilated. So we used the Cook Z stent. They come in, I think, 20 up to 35 millimeters. We used 2 overlapping 25 millimeter stents to achieve about the 8 centimeters of coverage as listed there.
Is this the Zenith stent?
The Cook Z stent.
Z stent.
Yeah, separate from the Zenith stent graft. These are metal stents with very wide interstices. So in theory, if we were to overlap at all with those hepatic veins, it may be okay. But we were able to confirm with IVUS that we were clear from that. This was a long reconstruction, about 42 centimeters length in total. We did use our Abre stents sized to our inflow from the distal portion at the common femoral veins. And we met the two in kissing fashion with about a centimeter of overlap into the Z stent before post-dilating. Here's the before and after images. Again, the first one on the left in prone position, showing that extensive collaterals, and then on the right here from our supine position intra-procedure. And then again, we have IVUS before and after, and I think for us the most important thing was just making sure that those hepatic veins were intact. And so this is a bit of a summary of all of the different tricks and techniques that we used along the way. And I think some of the biggest takeaways from this case, well actually first, not to be overlooked, and I do have at the bottom here that we have the medical therapy. So she was transitioned to Lovenox. After about a month, she was transitioned to Eliquis in the outpatient. She was on Plavix for 3 months. And then this is our imaging protocol that we followed. This was an in-house cross-sectional imaging, and then we followed her with duplex imaging after that. She did continue to have bilateral flank pain. We related to implantation of those stents, but her swelling improved markedly, and she is continuing to do better. And yeah, again, I think the key takeaways from this is, I mean, careful planning. This was months in the making, and consideration of open reconstruction first, and before coming up with this plan, and making sure that we had 2-team access, and our through-wire access was key for having the support to be able to perform this. That's all I have.
Another interesting. Oh, stay. Don't go yet.
That's all the time we have.
Well, we have 2 more minutes, so
Yeah,
good.
okay.
But very interesting, challenging case. My question is, I'm always nervous when we put like these 14, balloons and atretic. Like the lady did not have,
Right.
veins. It's not like they're clotted off or they're like, thrombosed. Maybe that's why she's still having that flank pain. I mean, what's the risk here of really rupturing all this with such big balloons when you have like congenital atretic veins?
Yeah,
I don't know the answer. I'm just asking.
Yeah, I couldn't quote a risk, but I mean, I think that's why we were so careful to sequentially. I mean, we used a number of balloons starting from the 8 millimeter size and working our way up to 10, 12, and 14. And so I think that gave us a little bit with those prolonged inflations.
Was the patient awake, sedated, or this is
She was
general
under
anesthesia?
general. Under
So
general.
you don't know if she's having pain or not
Mhm.
during the procedure, which makes it a little bit more, to me, a little bit more kind of worrisome.
Yeah.
The one thing about pain, though, is they all get pain,
get pain.
and so Sometimes the advantage of having them knocked out is it doesn't make you stop doing what you're supposed to be doing, right? Because the pain can be excruciating from these venous procedures.
For people, I mean, any consideration? I know they are not going to be that big, but covered stents, just in case. I mean, I know they are not as good. I mean, I totally see the why we don't want to do them, but I'm just still thinking of that atretic vein that you're trying to kind of pretty much establish up to 14 millimeters. Yeah.
I'm happy to answer all the questions on rupture in the cable segment. So I think there's a risk, for sure. There's a risk of rupture. And with that, I always have like a backup, a bailout covered cuff aortic stent. What generally happens is it tolerates the balloon angioplasty, and yes, the patients are in pain. I mean, you're going from, you know, like say angiohypostic to cannelloni. I mean, you're like really stretching this vessel. But generally, it does tolerate it. If there is a perforation, it tends to be a locally contained perforation because there's no inflow, outflow, right? There's really nothing coming in. And so generally, you can tamponade that with balloon, prolonged balloon inflation. And then once you restore flow with stenting, you have a low resistive bed. And so it's not like you restore flow to then continue to bleed into that area of perforation. And so generally, once you restore patency with stenting, it becomes a low resistive bed and it just, you know, inline flow without any progression of continued bleeding. So that's my experience. Now in the, I think that these cases, I think, like you said, the pain part, they're all going to have pain. So if you're going to pause on ballooning because of pain, I think that may provide or put you in a situation of a substandard prepping of the vessel, right? I mean, you've got to prep the vessel for the stent, or the stents do not expand. And when the stents don't expand, then you already started off with a bad procedure. So I think that generally it's always impressive when I started doing these. It's impressive how much you can go from nothing to a big pipe and how much it can tolerate it. But you do have to be careful where your wire is. So, you know, we've heard of stenting going into the spine. Across the spine, you don't want to do that. So the cross-sectional imaging, cross-table imaging, and IFS helps.
Thank you. Thank you very much.
Thank you.
Thanks.
So can we get Dr. Fatima next? The triple threat, peripartum cardiomyopathy complicated by cardiogenic shock and intracardiac thrombus.
Okay, my name is Shumail Fatima, and I just completed my heart failure internist fellowship at University Hospital's Harrington Heart and Vascular Institute, where I was mentored by Dr. Chantal Elam and Dr. June Lee, who's also the proceduralist on this case. And the case I'm presenting has a title of a triple threat peripartum cardiomyopathy complicated by cardiogenic shock and intracardiac thrombus. I have no disclosures pertinent to this talk. So here we have a 20-year-old female who's currently 38 weeks pregnant, and she's presenting with acute hypoxic respiratory failure. She's otherwise a healthy female and doesn't have any pertinent cardiovascular history prior to this presentation. Her vitals on arrival are listed as below. She was tachycardic with a heart rate of 160 beats per minute. Her blood pressure is stable, 134 by 92 millimeters of mercury. She's hypoxic with the stats of 76% on room air, and she's afebrile. Her pertinent diagnostic workup include a high-sensitive troponin I of 182 nanogram per liters. Her BNP is elevated at 2259 picogram per milliliters. Her chest X-ray revealed she has bilateral pulmonary edema, and a point-of-care ultrasound completed in the ER shows that her left ventricular ejection fraction is almost 15 to 20%. Based on this presentation, she's diagnosed with peripartum cardiomyopathy. So in the beginning, she was trialed on BiPAP in the ER, but she continues to desaturate. So ultimately, she ended up getting intubated for acute hypoxic respiratory failure and was transferred to medical ICU. At that time, she was also noted to have fetal tachycardia and decelerations, which basically means that her fetus is at distress as well. Given this complex presentation in this pregnant female with acute hypoxic respiratory failure and peripartum cardiomyopathy and fetal distress on top of that, requiring close coordination across multiple specialties. A multidisciplinary team comprising of obstetrics, maternal fetal medicine, advanced heart failure, and cardiothoracic surgery teams was engaged. There was a consensus that she needs to undergo an urgent cesarean section with closer hemodynamic monitoring, for which purpose a Swan-Ganz catheter was inserted. She goes to the OR and has an urgent C-section performed, to where she lost almost close to a liter of blood during the surgery. And at that time, she develops this shock, which is perioperative shock, mixed in etiology, both cardiogenic and hemorrhagic. To help her with the shock, she was started on norepinephrine, vasopressin, and milrinone drips, and also received 2 units of packed RBCs. She was stabilized on all of these strips. She delivers a healthy infant and returns to ICU. She remains on the pressor support at that time. A formal transthoracic echocardiogram was then ordered. And these are the findings. As you can see that she has the severely reduced left ventricular ejection fraction with global hypokinesis of the left ventricle. She also noted to have moderate to severe mitral regurgitation, some mild to moderate tricuspid regurgitation and mild pulmonary regurgitation as well, along with an elevated left ventricular systolic pressure of 50 millimeter of mercury. The interesting finding that was noted on this transthoracic echocardiogram was that there was a highly mobile echo density within the right atrium, as you can see on this imaging, and they recommended that we should further obtain a esophageal echocardiogram for confirmation. These are the findings of her urgent transesophageal echocardiogram that confirms that there is a mobile echo density in the right atrium. It was 2.5 millimeter thick, more than 6 centimeter in length, and it appeared to be attached to the Swan-Ganz catheter at the level of superior vena cava, and it most likely looked like it was a thrombus. You can also see it's extended into the right ventricle. It's crossing the tricuspid valve plane during the diastole. So this brings us to our clinical challenge, which is multifold in this patient, that we have a right atrial thrombus in transit. So we are dealing with cardiac challenges in this patient. She has peripartum cardiomyopathy. She's also in cardiogenic shock on multiple pressors. There are obstetric challenges. She just had a C-section done and lost almost a liter of blood and developed intrapartum hemorrhage. There are also hematologic challenges because as we can see, she has a right atrial thrombus, so she's increasingly thrombophilic and thrombogenicity. Again, we reached out to our multidisciplinary team that comprised of obstetric, maternal fetal medicine, advanced heart failure, and this time we also involved interventional cardiology teams. So the conversations we were having is that, is this patient suitable for systemic anticoagulation? And the decision was no, because she just had a C-section, had a bleeding during the surgery, lost blood, so it's unsafe for her to be anticoagulated for another 12 hours. However, as I said earlier, she does have this right atrial thrombus in transit, so there's a concern that it can dislodge and can lead to a pulmonary embolism in the patient who's already on presses with cardiogenic shock. So it was decided by the multidisciplinary team at that time that she should proceed with catheter-based thrombus extraction. She goes to the cath lab. And then she underwent this right femoral vein cannulation where 24 French Inari sheath was placed, an intracardiac echo-assisted thrombectomy of right atrial thrombus in transit with Inari trivert 24 and curved trivert 20 was performed. As you can see the image of that thrombus that was retrieved on the left side of the screen. Given abundance of caution that the patient did present with acute hypoxic respiratory failure, did not have the time to undergo a CT scan, a pulmonary angiogram was also performed to see if there is any PE that would also need to be managed, but fortunately she did not have any major PE at that time. Now she returns to the ICU, and a post-operative transthoracic echocardiogram was performed. And as you can see in the right atrium, the thrombus is now gone. After 12 hours were passed after the C-section, she was started on high-intensity heparin drip. And the next couple of days, she was safely extubated and was gradually weaned off all the inotropes and pressors that she was requiring for the cardiogenic shock and the sudden peripartum cardiomyopathy. Later during the hospitalization, she did undergo a cardiac MRI. There was no evidence of prior infarction, scarring, or any infiltrator process that can explain the origin of cardiomyopathy. She also underwent an extensive unremarkable hypercoagulability workup that included negative DVT scans in the lower extremities. So it kind of determined that the prothrombotic state was due to a combination of her pregnancy and peripartum cardiomyopathy. Before discharge, she was also enrolled in Rebirth trial, which is randomized evaluation of bromocriptine myocardial recovery therapy for peripartum cardiomyopathy. Was discharged on guideline-directed medical therapy and apixaban 5 milligram BID, which is a part of being enrolled in the Rebirth trial. So this is the follow-up transthoracic echocardiogram in 6 months and when she was seen in our women's heart clinic. And as you can see that her left ventricle ejection fraction is normalized to 60%. So the takeaways from this case are that the multidisciplinary coordination is critical in managing peripartum cardiogenic shock. Thromboembolism is common in peripartum period and warrants special consideration in cases that are complicated by peripartum cardiogenic shock. And catheter-based therapies are safe in these complex patients who are presented with this complex peripartum cardiomyopathy syndrome and have this shock, intracardiac thrombus, and have undergone recent cesarean delivery. And with that, I would conclude and take any questions.
Nice presentation. Because this clot was associated with a catheter, with the Swan, and you took the clot out, you took the catheter out, could you argue not to give her anticoagulation given recent C-section and everything else?
Yes, so that was the concern that even if we try to remove the Swan-Ganz catheter, which as you can see in the previous images was not removed at bedside or neither in the OR, she actually presented to the cath lab with the Swan-Ganz catheter and that if we try to remove it, it might dislodge that thrombus and that could lead to pulmonary embolism. However, as I mentioned, the fact that she did have this intrapartum hemorrhagic shock, it was not advised to have her systemically anticoagulate for another 12 hours. There was a risk of bleeding was pretty severe.
No, my point is you took the clot out, you
Yeah.
took the catheter out. So why anticoagulate after that?
Because we weren't sure if there's more thrombi, if she has more thrombi, like if she has like DVTs and if there is another.
Yeah, because I think you screened for DVTs but didn't see any, right?
They didn't screen it right after. So there was like some extensive workup that needed to be completed. And she was also thrombogenic at that point. So they weren't sure if she needed it or not.
Do you happen to have the right heart numbers as to how severe the shock was? I see that you mentioned.
I don't because she didn't have the shock develop in the MICU, so the shock actually first appeared in the OR, and we didn't have the numbers at the OR. The report that we got was that her blood pressure became severely soft after she lost the blood, and they had to start her on the vasopressors and vasoactive agents in addition to giving her 2 units of resuscitation. How low she was, we exactly don't know because that was in the OR records. But when she came back, she was on triple therapy, norepinephrine, epinephrine, and milrinone. We were able to get her off Levophed pretty quickly, but she had to go to the cath lab on 2 agents.
My follow-up question is, what would you do if she were to be in refractory shock? I know you gave the blood. I know you have her on quote-unquote 3 pressors.
Yeah.
What would be your next step if she were to be refractory?
In our institution, we do have a protocol that sometimes if these patients, for instance, if she would have presented declaring a shock, that these patients undergo cesarean sections on a VE ECMO assisters, via cesarean sections. We've had patients who've had VE ECMO assisted deliveries, and there was the question that brought up in her case as well when she was in the MICU, going to the C-section in the OR. However, because she was sort of stable at that time, they avoided cannulating her for the VE ECMO. But we've had these patients who are preemptively cannulated for VE ECMO, and that's why the cardiothoracic surgery team was already on board in case she needs it.
I mean, this is outstanding. I mean, sitting here and listening to the lecture, we all think this is, oh, wow, nice, doable. But to take the manpower, the teams involved, the people involved, the decision-making, maternal-fetal medicine, cardiothoracic surgery, intervention cardio. I mean, this is, kudos to the institution that can do all this to come up with such a result. So congratulations and thank you.
Thank you so much.
All right, let's keep moving so we stay on time. Dr. Awan, from sheath to stent, overcoming access hurdles in EVAR.
Good morning, everyone. Can you hear me? Yeah. So these are some tough cases to follow. Come on, how can you match with first in US case? So it's my honor to be part of this esteemed group. So I'm presenting a case of from sheath to stent navigating access challenges in EVAR. I do not have any disclosures, but now that I've finished fellowship, I'm actively looking for disclosures. So I have a 75-year-old patient with past medical history of hypertension. He was referred to us from the outside facility because of abdominal pain. He had a CT scan which was done, which showed abdominal aortic aneurysm of 8.1 centimeter, along with rectus sheath hematoma. His review of system was positive for abdominal pain and cough. Past medical history, he only had hypertension. He was an active smoker, and surgical history was non-contributory. He was stable vitally, but he did have mild abdominal tenders, otherwise unremarkable exam. And if you go over here, so you see this is the abdominal, this is the aorta, you probably see the renal artery coming back, and this is the large aneurysm, and over there you'll also see some rectus sheath hematoma. See over here. We believe the rectus sheath hematoma was the incidental finding. And this is the coronal view. In the coronal view, if you pay attention, you'll notice that this is a very tortuous aorta, and it's not very straightforward. The neck, which we got, was about like 10 millimeter, so we felt that it was an adequate landing, and there was some tortuosity in the iliac, and if you look at the common femoral artery, they look like they're appropriate size for access. So, yeah, here you can see we also have the sagittal view, and if you see the neck is about like 10 millimeter, pretty decent size. And this is where we got it. The neck was about 28 millimeter, so we normally oversize by 20%, so it's about 32 millimeter that we decided. The aneurysm, they got 7.9. Our radiologist got 8.1. I got 8.3, so it's between 7.9 to 8.3. The distal iliac was 12 and 15 millimeter, and common femoral were looking pretty good. As with all aortic aneurysm, we do have multidisciplinary approach. We discussed the case with our vascular surgery. We reviewed the anatomy. So we are in a unique position where our cardiac thoracic surgeon is our vascular surgeon, and he takes care of the open stuff, and we do all endovascular stuff. So we decided to proceed with EVAR. Our plan was to get bilateral groin access. I normally do pre-close with proglides and 30 millimeter device. And my plan, because the right was more status short, so I decided to deploy the main limb through the right side. For those of you who don't do EVAR, we use 16 French sheet for the main body and about 12 French for the contralateral limb. And because of tortuosity, kind of shorter neck, we decided to deploy endo anchors. So we got ultrasound guided access, and can we play the next video? But it was a good stick. Yeah, you can see the access was pretty good. And then, okay, feeling good about it. So I was unable to cross with the J wire, tried the woolly wire, still had difficulty. So I'm like, okay, let me take another picture just to make sure we don't have any issues. And that's what we see. And when I saw this, I had an intense visceral response. Obviously, you are doing a semi-urgent / emergent case on a patient with abdominal pain. You need 2 large bore access. You have a great vessel, and then this happened. So obviously, the patient was hemodynamically stable, which worked in my favor. So I got time to think about it. So one of the options was to stop and go back to Pakistan, where I came from. I did take that into consideration, but then I looked at other options. Other options also included like deploy an AUI, which is aortic uniiliac graft, just deploy the main body and the left side, and do like a FEM-FEM. The third option was to try to fix this one. I also called my vascular surgeon, and we discussed the case briefly with him, and I told him the plan, and I asked him, do you want to take the patient to OR? He's like, no, I'm good. So, but he said that, okay, if we're able to do the AUI, he can do the FEM-FEM, so that was quite helpful. So I got the access on the left side. At that time, I was very cautious, telling myself not to have any more complication. So the access was good. And obviously, when we look at the abdominal aortogram, you see it's not as straightforward shot. It's not as easy as most of the cases that we do. It's very tortuous and to go up and over. So I did not want to push too much from the right side, because I felt like if I be too aggressive from the right side, I can extend the dissection into the aorta. So the plan was to go up and over. I tried to go with OmniFlush. I wasn't successful. So I used rim catheter and went up and over. I did balloon angioplasty with 6 millimeter, and then I was able to cross the true lumen. I confirmed that with IVUS. I was in the true lumen, and then we did an abdominal aortogram which showed that we are pretty much true lumen. We ballooned both the right and left common iliac arteries. And at that time, I switched some plan. My plan was initially to deploy perclose on the right side, but now I have dissection over there. So I decided I will not do the perclose, I will do menta at the end. I did deploy perclose on the left side. The second change in the plan was that I will deploy the main body to the left side. Obviously it was tortuous, not as much of a straight shot. One could argue you can go from there and take care of it later on. But I felt like if I'm deploying a 16 French sheet, I probably will have better control and have it deployed on the better side where I have better access control. So then I did the aortogram. It doesn't work all the time. So we deployed the main body. It was 32 millimeter, and we deployed the main body. After the deployment of the main body, we recrossed from the right side. Again, we have to be careful, like you have some dissection, so don't to pull it too back and come back into the dissection plane. So I just briefly was pulled back and was able to rewire it quite easily with glide wire advantage. And there I'm doing the spin test. And then I deployed the right limb and then the left limb.
Can we go next video? It's not, this clicker may need batteries or something, I don't know.
So because of the short neck and tortuous anatomy, I decided to deploy endo anchors. We deployed 4 endo anchors. I normally do it as a zoom in view, deployed in LAO and RAO view. When I was, after the deployment, my wire came back and I was trying to rewire it and had another dissection on the left external iliac, so I placed a 12 millimeter self-expanding stent. I was did, it looked pretty good, and then did left iliac angiogram. And the final angiogram was done. It showed no evidence of endoleak. The stent looked pretty good, and this is pretty much done. This was done in December of 2023. I recently saw him in June. It's almost 1.5 years. There's no evidence of endoleak. He does have mild stenosis on the right external iliac artery, which we are monitoring about 40–50%. He's asymptomatic. He's doing good. Yeah, so for the hemostasis, I deployed the menta on the right side. I took an angiogram, which looked pretty good, and I deployed the perclose on the left side. And so again, for the large bore access, optimal vascular access is a critical determinant of procedure success. In cases of arterial dissection, upper aortic approach can facilitate wire traverser, and balloon angioplasty may be employed to re-expand true lumen and aid in wire crossing. Additionally, in anatomically challenged cases with vascular tortuosity, the use of endo anchors can provide structural stabilization, improving device positioning and long-term durability. So that's it from my side.
Thank you. Thank you. Very good case. Just, you know, I've done a lot of research on access, and the only thing I don't like, and I know some people do it, is to take a picture with the microcatheter sheath. I mean, I could tell from the first picture you showed there was a tip dissection.
Yeah, that's what it was.
And then you wire it, and the wire goes subintimal, and you get into. Yeah. I personally don't. If you have good ultrasound guided access and you have micropuncture used fluoroscopy and ultrasound combined, and you already took a fluoro, you know you're at the middle of the head of the femur. I put a sheath and put the wire and take the angiogram with the wire. I think that's where, I mean, it all went wrong after that micropuncture sheath tip.
I completely agree with you. My microcatheter sheet was against the wall, and then when I did the injection, that's what caused the dissection. I also tend not to do it, but again, like in the large bore access, when I'm doing, I have to place like 16 and 18 French sheet. I just I think it's just me being paranoid, just trying to be sure before.
I mean, we do it all the time. I do TAVR too, and we do it all the time. And I mean, that's one thing I don't do. Don't take, you know, yeah. But anyway, thank you very much.
Well taken. Thank you.
All right, we'll keep going just again for the sake of time.
Next speaker is Dr. Farid, a hybrid approach to acute cardiorenal syndrome from iliocaval fistula.
There it is. Okay, I'm Franklin Farid. I just finished my vascular surgery fellowship in Dallas at Baylor Scott & White. Thank you to the leaders at CVI for having me. I have no disclosures. So this is a case of a gentleman, 71 years old, who presented as a transfer to our hospital. His chief complaint for going to the hospital was shortness of breath that he'd had for a couple of days, progressive. Interestingly, he'd also had a recent onset of kind of right low back and hip pain, and prior to his presentation to the hospital, had sought care for this and gotten injected with steroids in his low back. So he had been having some low back symptoms. His pertinent medical history, he had coronary artery disease characterized by an MI in 1990 that was neither treated surgically or with a stent yet. He had hypertension, diabetes, and was a former smoker and had no known history of heart failure or renal failure. So when he presented to us, he was found to be an acute diastolic heart failure. He'd had progressive AKI, and on his workup, after being diagnosed with these things, he was diagnosed with this iliac aneurysm. He, on physical exam, had anasarca, most prominent in his bilateral lower extremities, and on his review systems, this was a new symptom in addition to weight gain. Here's his chest x-ray. You can see the pulmonary or interstitial edema that was not explained by kind of anything else, no pneumonia, obviously no ARDS or anything like that. Here, this echo was done at the outside hospital, so we didn't have the images, but ultimately the ejection fraction was preserved in kind of a normal appearing echocardiogram with the exception of some abnormal left ventricular diastolic filling. Pictured here on the left, this is a graph of his transaminases. They had an acute spike up to 420. Spoiler alert, 6 months later they had returned to normal. On the graph on the right, you can see his kidney function had previously been normal. Creatinine had spiked to a peak of 3.3, and his GFR had decreased to a nadir of 19. Here's his preoperative scan. You can see a very, very large right common iliac aneurysm that was presumably the cause of his low back pain. Pictured there, you can also see there is a hypogastric aneurysm and a left small iliac aneurysm as well. In retrospect, there is filling of the IVC with contrast on this arterial phase. This is not a delayed phase, but you can see that the IVC is filled with contrast. In the report for this particular scan that was done at the outside hospital, there's no mention of a fistula or kind of aberrancy in the filling of the IVC. There's no mention. So it escaped the attention of a lot of physicians. Oops, excuse me. So the clinical challenge in this case was that his diagnosis of the fistula wasn't made until we went to repair the aneurysm. In our head, we are repairing this aneurysm because it's very large and because of the risk of rupture. And we're doing so in the context of acute renal failure and the risk of kind of propagating a contrast nephropathy, and in the context of a new diagnosis of heart failure. So his course was kind of tortuous. His first operation, he underwent an EVAR with coiling and covering of the right hypogastric artery. In an aneurysm of that size in the right common iliac, it presents a technical challenge in that it really angulates the takeoff of the external and internal iliac arteries. So access to these arteries was pretty challenging, and ultimately what we ended up doing was coiling the hypogastric by going up and over from the left and using a steerable sheath to coil. After we coiled, we proceeded with the EVAR, used a 23 millimeter graft, and extended down past the bifurcation of that common iliac artery. So here's the angiogram, and this is the moment we realized he had a fistula. So until this moment, we kind of were not operating under the assumption that there was a fistula. But it all kind of came to light. We saw that the IVC was lighting right up, and we were like, well, this explains everything. So here's his repair. You can see the coils in the right hypogastric, and you can see a satisfactory repair with no evidence of any endoleak. So going back, he had persistent symptoms of low back pain, kind of low back and hip pain, and none of his symptoms related to a shortness of breath or kidney failure that had progressed to renal replacement at this point. None of these had improved, so he underwent a CT scan, and it demonstrated a type 1B endoleak. The right limb of the graft had slipped back into the aneurysm, and so it was pretty obvious that this was the source of the symptoms. So we took him back and we placed an extension prosthesis to address this. His symptoms persisted. He was rescanned, and he ended up having a type 1A endoleak. And I think it's for, these things happen for kind of the same reason. The aneurysm had kind of pulled the graft into it, so from proximally and from distally. So he required extensions from both directions, essentially. So he underwent kind of we addressed this with just a cuff at the proximal part of the repair. And his symptoms again persisted. So he was rescanned, and it was determined that he had a type 2 endoleak from the right hypogastric artery that was inadequately coiled. So at this point, we kind of had no other option but to go in and ligate this from an open approach. So we did a midline laparotomy. We exposed the aneurysm and the bifurcation of the iliac, and we simply just ligated the right internal iliac artery. We also ligated the IMA as a potential source of endoleak. So after this, he had kind of a normal expected convalescence after an open surgery. His symptoms of heart failure resolved. His oxygen requirement decreased, and he was discharged ultimately on room air. His BNP, which originally was 8,000 on presentation, had improved to 852. His transaminases returned to normal, and his requirement for continuous renal replacement therapy progressively improved, and at his 6-month follow-up, he was demonstrating normal kidney function. So this is his scan after 6 months of after his repair. There is a little bit of shrinkage in that size of the aneurysm sac, but as you can see, everything's in good position, well opposed, and with no evidence of endoleak. So in conclusion, a vascular etiology for cardiorenal syndrome is exceedingly uncommon, but I think out of the vascular etiologies, a fistula is probably going to be the main culprit. So if an aneurysm is identified in the context of new onset heart failure, a fistula should be considered. Aneurysms can be symptomatic, and they usually present with pain, but sometimes they can fistulize. This is true for any aneurysm in the arterial tree. And a hybrid repair may be warranted with complex anatomy.
Thank you very much. Thank you. So one quick question for you. I'm, again, absolutely not a surgeon, and I may not know the answer to this, but how urgent was this? Why could not this guy be treated for his heart failure, get his fluid status better, get his kidney function a little bit better, and then do this like open, for example, because you still have this residual big, burden of clot, and the shrinkage is not going to happen that much. So there's still like a mass effect there. Long term, does that cause any issues? And I mean, how urgent was this needed to be done endovascularly?
We didn't feel a sense of urgency. At first, we did want his symptoms of heart failure and kidney failure to be addressed, but they weren't improving. And he didn't, it's a tertiary cardiovascular center, so we have nephrologists, we have all of that. He was responding a little bit to diuresis, but not in a satisfactory way. Because of its size, a 10-centimeter iliac aneurysm, we were concerned for rupture, especially in the context of him having pain. So there was a sense of urgency, and we did prioritize his heart failure and his kidney failure, but ultimately, because they weren't improving, we went ahead and planned the repair. Again, not knowing that this was a fistula and not knowing that repairing this would resolve all of his issues. But yeah, I think, in a case like his, I think endovascular would be the preferred approach because of just the morbidity associated with an open repair. And nowadays it's preferred.
Well, thank you very much. We move to our last presenter, Dr. Varun. When thrombectomy backfires, worsening hypoxia and hemoptysis during PE thrombectomy.
Good afternoon, everyone. I'm Varun Jain, academic hospitalist. The proceduralist here was Dr. Roy. So this is a case where I presented about thrombectomy complicated. I have no financial disclosures here. So the case is of a 53-year-old male who has a past medical history of paroxysmal atrial fibrillation. He's not on any anticoagulation, morbid obesity, BMI of 45, and sleep apnea, not using CPAP. So he was trying to lose weight, prolonged fasting, was sedentary because of this. He came in with shortness of breath for last 48 hours to the hospital. So when he came in, he was in AFib with RVR, 160s per minute, hemodynamically stable. He was hypoxic, requiring 4 liters of oxygen. So initial CTA chest showed a massive pulmonary embolism, saddle PE. This one shows his PE in the right side. And this is again clot burden, showing PE on both the sides, and now this one on the left side again. So given all these findings, we thought, what's the next step? And this is again the CAT scan showing his right heart strain, increased RV-LV ratio. So the CAT scan here shows his right pulmonary lower lobe infarct. And so the question was, what are the next steps? Given all these steps which are possible, we decided to go for catheter direct thrombectomy in this guy. So we proceeded with a NRE T24 system. His mean PA pressures were noted to be 42. His PA sats were 52%. So we started the first aspiration attempt in his right PA. It was extremely large thrombus burden. It was clotting his catheter, even the sheath. Because of that, the sheath and the catheter actually had to be removed, pulled out, and then reinserted again. After this was the initial clot which came out, showed both acute and subacute components.
You tried aspirating the sheath and then nothing?
No, the clot was even clogging the sheath also, so that the sheath also had to be removed. So after this, we went in again, and the right PA angiogram showed good improvement on the right side. There was good flow. This is in the now main pulmonary trunk, removal of the saddle thrombus from here. Then we shot the left side. There's still a clot burden. We had not aspirated the left yet. So aspiration was started after this shot. So the patient immediately felt better after the right sided was done. Thrombectomy, he felt better. And after that, we started to attempt the left side. While doing so, he started having a coughing bout, violently coughing. And after that, he started having some hemoptysis, and his oxygen saturations dropped 60%. So now, because of this, we were concerned what's going on. So what were the differentials here then? So the most common differential here, what we are always worried about, is any catheter or wire-induced injury. That was something we were worried about. And then you also have differentials of pulmonary perfusion injury or worsening pulmonary infarctions. So because this was interposterior, suspect was catheter wire-induced perforation. Because of his BMI, we couldn't lay him on the position where for his the right lateral position because the cath table was very narrow. Patient was immediately intubated because his saturations were low. However, he remained hypoxemic despite being on 100% FiO2. His saturations remained 60%. We did not notice a lot of blood in the endotracheal tube, so we called anesthesia and pulmonary to come by. Pulmonary did a flexible bronchoscopy immediately if they were thinking whether he needs a selective bronchial blocker placement. However, did not show any significant bronchial bleed on the bronchoscopy, and the patient remained hypoxemic. He was 60% on FiO2 of 100%. His hemodynamics were stable. His blood pressures were 130s to 140s while on this. So because of being consistently hypoxemic, we decided to put in a VV ECMO. We anyways had access, so we went ahead and placed a 27 French Avalon catheter and initiated VV ECMO immediately. Following this, his saturations improved to 97%. And after this, thrombectomy was aborted, and then our plan was to then take him to the CT scan and then ICU. So immediate CT scan showed worsening pulmonary infiltrates bilaterally, more on the right side right now. So after this, he was in the ICU. We were trying to figure out what was the etiology of his sudden respiratory failure. Because he was on ECMO, he was on anticoagulation, but his hemoglobin stayed stable. Despite being on anticoagulation, we were watching his counts closely. Then we spoke to pulmonary and radiology, discussed what the possible options, and then, because his HNH was stable, we were thinking more in terms of pulmonary perfusion injury in this case. Treatment was initiated in the ICU with lung protective strategies, empiric antibiotics. Initial echo showed an ejection fraction of 20 to 25. He was on minimal pressors while on being intubated. He continued to be in FA with RVR. We tried to shock him, but he failed cardioversion, so he was started on amiodarone, bolus, and drip. So a repeat CT scan was done after this, after 3 days again. He did clinically improve. ECMO was decannulated after 48 hours. And then this is the repeat CAT scan now showing worsening consolidations again. Now this is more on the right side again. Sorry, the left side. So resolution of the challenge. So antibiotics were continued for 7 days empirically. He was extubated finally after 7 days to nasal cannula. He underwent a cardioversion, was fine after that. His repeat echo showed ejection fraction of 40 to 45. His RV had showed much more improvement, was mildly dilated, only mildly decreased RV systolic function. Eventually, he was discharged home after 14 days on Eliquis, and he came off oxygen and was discharged home. The key learning points on this was hemoptysis and hypoxia is a complication which can happen during thrombectomy or immediate post-thrombectomy. Pulmonary reperfusion injury is one of the differentials, but very difficult to diagnose. There is no real way we can actually say this is a pulmonary reperfusion injury. Management is only supportive. In this case, we did VV ECMO, and that is a potential treatment strategy in such cases who develop severe hypoxia despite everything what happened.
So, a great presentation. I have a question. Many times I'm faced with a PE activation. CT shows infarction. Maybe they presented a little bit late. Does the presence of an infarction change your management strategy at all? Or does the size of the infarction cause you to change your strategy?
Usually not, because in the end, it's the hemodynamics which matter more. So if it's high-risk PE, and we try to, pulmonary infarction will resolve on it usually. So we try to continue the same way if there is infarction or no infarction.
Well, I mean, to me it does. Not that you don't need to treat the PE. You don't want to use TPA. The only person we've had to open and extract some clot from was somebody that did not, they did not diagnose the infarction on the original CT because it was probably small, but later on showed us to be big. And we did catheter-directed thrombolysis with ECOS, and they bled to heck into their thorax. So maybe if you can do retrieval rather than TPA in these people, I think it's more appropriate if they have an infarct.
True.
Well, thank you very much. Thank you, everybody.
Thank you, everyone.
Great session. Thank you.